Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Mike McSherry. Mike McSherry is a successful serial entrepreneur, having started and sold several large mobile and internet companies over the past 20 years. Mike currently serves as CEO of Xealth, a digital prescribing and analytics platform integrated into healthcare electronic medical records. He and his team incubated Xealth at Providence St. Joseph Health while he was the entrepreneur in residence. Prior to Xealth, Mike was CEO of Swype, an innovative touchscreen keyboard installed on over 1 billion smartphones and tablets, which he sold to Nuance for over 100 million in 2011. He was also co-founder for Boost Mobile, which is now Sprint's prepaid service with several billion in annual revenues, and Xevo, which was the largest web development company in Australia and New Zealand with over 300 employees. Mike moved to Australia during his time with Microsoft, where he ran the MSN portal and e-commerce activities. He also held several product roles within Microsoft in the United States. Mike is an active angel investor, a board member, mentor to startup companies and nonprofits, and he lives in Seattle with his wife, 2 boys, dog, and active travel and adventure pursuits. Mike, welcome to the show.
Thank you very much for having me, guys.
It's super exciting to have you on the show, Mike. You've really led an absolutely thrilling career in tech. You've built 6 companies, you've had successful exits and profound learnings along the journey, and now you're leading Xealth. This is your 6th company, first company in healthcare. And I think as you've definitely come to realize, you have to be a certain kind of crazy to build in healthcare. So my question where I wanted to start the conversation, after you successfully exited Swype to Nuance, I was curious what inspired you to join Providence as their entrepreneur in residence and actually go all in healthcare?
Well, thanks for the background. Probably a couple of dimensions. Swype was invented for people with disabilities as an easier means of entering text and communicating. And when we sold Swype, we set aside a couple % of the company for a nonprofit foundation that to this day continues to give grants for disability-related technology innovation. So I got into the world of assistive technologies, and I went to, I saw the world's fastest hands-free text typing, a guy in a wheelchair just using an eye tracing software. So I got exposed to trying to help people with disabilities, which turns out all of us, all of us have, some form of disability or another, and certainly as we age, encounter that more and more. We sold Swype to Nuance, and Nuance has a large healthcare practice and played in the voice recognition, business. I was on the mobile side of that. Nuance was powering Alexa and Siri and those things, but got exposed to Nuance's breadth of healthcare offerings. And during that time, I joined the board of a local hospital system. And as I was leaving Nuance, it merged with Providence, and I met the CEO of Providence. And so he was asking me what I was going to do post Nuance, and I'm like, oh, I'm sure another startup. And he, asked me to consider something in healthcare and introduced me to a couple of people, including Aaron Martin, who is the head of the innovation group and a newly, founded venture arm of Providence. And so that led to Providence hiring my team and I in as entrepreneurs in residence to sort of come up with blue sky ideas in healthcare, coming from an orthogonal point of view with our success in technology and internet, coming in to see what problems we could potentially solve in healthcare.
Mm-hmm. That's great. And I think early on, while you were at Providence as their entrepreneurs in residence, you realized that free market dynamics and incentive structures that work in other markets don't necessarily work the same in healthcare. What's the biggest difference you've noticed from your previous companies and compare that to Xealth?
Well, first off is, we literally cycled through 70 different ideas. We jokingly would say free range EIRs, what about this? What about that? And I got to say a big part of our exploration, myself and my founders, we'd like to lead healthy lives. We like to think that we focus on sort of health maintenance, which is, exercise and nutrition and, living, sort of quality lives. And so we spent a lot on like, well, geez, isn't prevention the root of all evils in healthcare? Like, wouldn't you try to focus on preventing diseases rather than like just trying to, cure them? And so we literally cycled through dozens of ideas around that, with little realization that healthcare actually doesn't want to pay for prevention. Nobody in the ecosystem is really, set up or incented to structure on long-term wellness or prevention. And so we quite honestly burn through lots of cycles and calories, on these preventative type of efforts. And so that kind of took a while to unravel on that front. I was not privy to the health equity kind of considerations. Variable price structuring, flights have different prices depending upon the availability and seat selection. Same thing with hotels, same thing with a lot of things in life. And so, why wouldn't you just put, demand aggregation and yield pricing on booking appointment spots at relevant and convenient times? But then you realize that severely disadvantages the poor and vulnerable, and that's not where we want to take society. So as you kind of contemplate like how healthcare and the economic financing has been set up behind it all, you really need to understand the incentives of the constituent group you're trying to sell to, be it pharma or payer or provider or medical device, et cetera. And they all have their economic incentives that drive behaviors. And it is incredibly challenging in the US. You almost have to play four-dimensional chess because, yes, this is good for the patient, but is it good for the provider? Is it good for the payer? What about the device maker that's in the mix, or the pharma? Or like, you really have to like consider the ramifications of the ecosystem through and through to truly understand if that business model or product proposition will actually resonate and get deployed and scale.
And I guess, Mike, I think one thing to unpack a bit more that you mentioned is you went through dozens of ideas when you were at Providence before you set it on Xealth. Could you share a bit about how long was that process before you got to Xealth? And even when you got to Xealth early on, how did you know that one might have more legs in terms of starting a business?
Yeah, so we ultimately had, because we were brought in and we pre-negotiated our spin-out terms, the IP transfer, the equity ownership structures, all of that was pre-negotiated prior coming into the organization. So we knew that we're coming in to like come up with an idea and spin it out. And so if it was going to be a startup oriented business, you look at a total addressable market. Is this a big enough problem? We heard lots and lots of problems but then you just took a look at it like, well, is this just for Providence or is this for the industry, or this solves this like little discrete pain point, but does that become a company or then a platform and et cetera, that might warrant venture backing and frankly, spending our time and energy trying to solve that problem. We naively, we went in and we would oh, oncology, that's a big problem. Let's go meet with, the Providence oncologists. And next thing you know, there'd be 10 of them in a room, chief oncology. We're like burning through $5,000 in a 1 hour meeting. And they're telling us problems and it's all flying over our head. And quickly we realized I'm not going to solve a very specific disease state problem unless one of these doctors wants to quit and come join and has a burning desire to solve problem X in this disease state. So we took a look at lens of our capabilities, our software technology background, our consumerism, engagement strategies, and all the different businesses I've been involved in, and sort of honed in on where we think we could actually deliver a tangible benefit to the healthcare ecosystem. And we went back to Xealth, which and literally we cycled through 70 different ideas. And you asked a question about how long. So I'll be very transparent on the structure that I negotiated with Providence. There were 4 of us, and it was a 6-month contract that they hired us into. And all 4 of us got paid the exact same. And over that 6-month period, we came forth with n number of ideas, and we would vet them in a monthly call, and have various meetings around the Providence organization. And after 6 months, quite honestly, we didn't have shit to show for it. Aaron Martin could have said, well, I blew 6 months of salary on 4 of you, and you don't really have anything to show for it, so you're out of here. But he's like, you're thinking about the problems in a very structured, tangible way. I like where you guys are going, keep going at it. And it was in the next 6-month contract cycle that we actually came up with the idea for Xealth and built a prototype and had launched it inside of Providence's Epic environment. And then it was in a subsequent 6-month contract renewal that we aligned against several other provider systems. We successfully deployed it in other provider systems, and that precipitated us spinning out the company. So we spent 18 months, 6 months of just random brainstorming, nothing to show for it. The next 6 months building a prototype, and then the next 6 months scaling to other hospital systems and spinning it out and raising venture capital. So I basically went from, I had been on the board of a system, but boards look at financials and big picture things. Startups solve day-to-day problems. So it took basically, let's say, 9 months to come up with the germination of Xealth and then build a prototype, and then another 9 months of scaling it inside Providence, proving it was working, scaling it to other hospital systems, and on the backs of that, spinning it out and raising venture capital.
Wow, Mike, what an incredible journey, and probably pretty unique, because I don't know how many systems out there like Providence would actually bring in entrepreneurs in residence and have these 6-month cycles. But it seems like a really great model if you have the right team and talented team and experience like yours to do that. I was wondering, usually I think when you're starting companies, you maybe at the very least when you're building out your initial, let's call it MVP, even though probably in healthcare it has to be more than just MVP. But usually you ideally have at least a handful of early customer partners, that way you're getting feedback on it from multiple different parties. Healthcare is a bit unique, where it seems like in this case, it'd be hard to have the bandwidth to do it with more than just Providence to start. Is that something that you think is just going to be the case in healthcare, where given the complexities of it, if you're going to do something like Xealth, you would have to start with that one system partner? I think it's a very common thing we see in healthcare. And is there any way around that? Or is that just how it is in healthcare? You got to start with one major partner and then hope that that problem is validated everywhere else.
I think we got lucky. Look, we brought a tangible skill into Providence of, having proven ourselves as technologists, and Providence had just set up a venture capital arm, and it's not uncommon in the world of, generic financial venture capitalists to have EIRs on staff that, might have been someone who successfully sold a company that was a portfolio investment. Hey, why don't you hang your hat around here for a while, and then we've got first dibs on investing in your next company. So it's a pretty common structure in venture capital, over decades. So Providence sort of emulated on that. Providence has successfully spun out, at least 3 companies from their digital innovation group. The other 2, which was Circle and which was sold to Wildflower, and DexCare, which successfully spun out and raised money. Both of those were very defined products, and they recruited a CEO to kind of come in and spin out those companies. Whereas we had more latitude to come up with an idea of our own. And that's kind of a tough proposition. I don't know if you'd give that much latitude to a group that didn't really have healthcare chops and background like us. I sort of feel like we threaded the needle, and timing was right, and I sort of feel successful with that. But again, we've started and scaled a lot of companies together. My founding team, the 4 of us, we've in some cases, one of us have worked together literally for I think 28 years now in multiple companies. And my CFO and my CTO have worked with me for 15 years. So, these are kind of strong, loyal teams. We solve problems together. You specifically asked about how do you vet that it's a problem for one, but then it's potentially scalable and a problem for others. we very deliberately in our exercise of looking for these ideas, tried to ascertain, is this a problem for the industry? Is it a problem for Providence? If we solve it for Providence, how scalable would it be? And this is where I give a lot of credit to UPMC. So Providence did a lot of info sharing. So I came from the mobile world, and you guys are in Canada, right? Like BlackBerry is your history. Like you think BlackBerry was sharing the product roadmaps with Nokia and Apple and Samsung? Hell no. Whereas in healthcare, Providence shares, here's what we're working on with all the other systems. Maybe not the ones immediately in their backyard, but like to a company like UPMC or Kaiser or Geisinger or whatever, like they're more than happy to like share what they're working on and formulating strategies around, et cetera. And they hosted a lot of systems. Seattle's an easy place for these innovation and CIOs to visit because of you can always dovetail an Amazon and Microsoft meeting on it. So I get to meet with lots of other provider systems as we went through our EIR and incubation journey. So I get to vet this idea with frankly dozens of provider systems as before we even spun out. And UPMC saw a prototype and they said, if you can show that working in our Epic environment, I will want to use this technology and invest in this company. And that's what precipitated Xealth spinning out. So I kind of had deal flow, if you will, coming to me at executive levels, CIO levels, chief innovation officers, chief digital officers, et cetera, because they were just coming by sharing learned experiences with Providence, and I could get roped in to have like anywhere from a 5-minute to hour-long session to talk about the ideation process that I was on, and then subsequently when we built up the Xealth prototype, kind of be able to incubate and show some of that along the way. So again, back to the original question, we very diligently tried to like solve a problem that we thought might have industry-wide ramifications, because Boost is the nation's fourth network. In your bio, Dish bought it from Sprint for $1.5 billion last year, and Swype technology, that style of drawing on a keyboard, is now on every iPhone and Android phone in the world. And so I wanted to do something meaningful at scale. And my goal is that this becomes the default prescribing and monitoring platform for the US provider landscape, if not, international aspirations.
That's awesome. So Mike, actually, you highlighted throughout that answer your focus on having a key team. And, you've worked with your four or the other three founders for almost 20 years at this point. In a previous interview, you actually shared how culture, camaraderie, and having a shared vision for the future is an underrated value of yours as you build out and scale these companies to 300 plus people. How do you foster a culture that's built around camaraderie and a shared vision?
It first off comes with trust. And I have a very transparent culture with my company. I share board material with the entire company, the pros, the cons. Here's what's going on with the business. Here's board dynamics back, et cetera. And so, and I think with that shared trust can come from, it can also line up against a mission of what you're trying to do. And Swype was a cool technology, but it was founded to solve a problem for people with disabilities. That was the underlying mission for why that technology was invented. And we wanted to take our technical skills and try and make the world a better place in healthcare. And we knew just from afar the dysfunction in the US healthcare. So how could we use some of our technology chops to try and cut costs, make the world a better place, have more engaged patients, and I've seen the value of technology in our consumer lives, and it was absent in sort of patient lives. And so how do you introduce technology that's more seamless to the clinicians and then to the patients? And that's sort of the problem that we're solving. So trust on the team, the transparency, and in a mission of what you're trying to accomplish, and then attack it in sort of a meaningful and structured manner. I'd like to think we're good operators. We're not like changing dimensions and strategies on the fly. We operate in structured cadence. Let's not say you don't have to adjust to the winds of change. Certainly now in this like dynamic of potentially, frankly, I think we're in a recession now, and how does that play into our provider customers and how they need to respond? How does it play into us and our financial metrics of how we need to accommodate for what this might mean for capital allocation and things like that. So but trying to take my team through that journey as transparently as possible, I think lends itself to people just trusting and being loyal with me.
It sounds like you start with high trust at the very beginning, as opposed to some other groups who maybe trust has to be earned over time. You start with default trust at Xealth, it looks like.
Yeah, there's like, innocent until proven guilty. I just kind of go in. The world's generally a pretty good spot, and most people come from a point of view of like wanting to help and improve the world, and healthcare has that in spades. But you also need that empathy, and this is the Gordian knot of healthcare. Like empathy and well intentions just don't always move the needle on what the economics align to in healthcare, and that's the most frustrating part here. Is like everybody can nod their head in agreement that yes, this makes sense. It still might not happen for XYZ reasons.
Yeah, I would say having been in digital health entrepreneurship for almost a decade and seeing a lot of other folks work in the space, one of the most difficult things to understand early on is that just because you build a new product or solution that helps a patient or helps a provider, unfortunately doesn't mean there's a viable business model to sustain and grow that innovation. It's just it's an unfortunate circumstance of healthcare. But luckily, I think both of us have had an opportunity to do something good, and it's worked out so far, which is great. We had a guest question actually. So Dr. Razu Shrestha, the Chief Strategy and Transformation Officer at Atrium Health, one of your health system customers and investors, had a question for you, and he did warn this may not be an easy question, so heads up on that. He said, Xealth has clearly established itself as an important bridge between the clinician's world and that of patients. How will you make this into an indispensable asset for any CIO?
Well, and that's let me back up a little bit for those who don't fully understand what Xealth is. Is we're a software platform that lets clinicians recommend or prescribe or order digital tools for patients, and then be able to monitor the patient activity in that different app or device or service. And so we've integrated dozens of different vendors, the digital health formulary, if you will, for the provider systems. And we've integrated lots of different content, video catalog vendors, your digital therapeutic apps in diabetes management, behavioral health, maternity care, surgical prep and pathway solutions. We'll find a way to work with you guys on that front. And then we've done product prescribing or medical, prep kits to send to patients' homes, or a number of meal delivery services. So we're not really, we don't really care what goes into our prescribing workflow. It's up to the hospital systems to define that. And then, on the monitoring side, we've done a number of glucometer monitoring solutions, for diabetes management, or Philips ResMed CPAP devices, or these remote patient monitoring platforms to track CHF recovery and things like that. So we've integrated dozens of different apps and services on that. So specifically to the question of how do we become indispensable, quite honestly, I think hospital systems are at a crossroads now, and they're facing their own financial headwinds of the payers are competing with them, and patient volumes are down in many cases against COVID, and the prioritization against COVID, and And then they've lost a lot of money in their investment, kind of endowments and things like that. So they're at a crossroads here of, can they invest in a digital health future? Or can they afford to, or can they afford not to? Because you've got lots and lots of retailers and payers and new startups and trying to, take away patient volumes and care delivery and things like that. And, quite honestly, some are going to say, I can't afford to keep up in this arms race, the small community hospital systems. But if they want to be a player at regional level and play a role in, primary care for the community, and then into the specialty and surgical operations, they're going to have to invest in a digital future. And I think those that are investing in a digital future are going to have to take a look at the engagement modalities, the automation tools, the cost structures, the cost containment that a variety of these digital tools can provide, from either prepping the patient to form filling the patient, or ensuring their preparation before a surgical procedure or a consult, or then on the care management, there's an inexorable movement towards value-based care, who knows what duration or timeline. But there's no denying now that apps and remote patient monitoring devices and different disease state management done on asynchronous or remote or app, patient generated, kind of like, self-enrollment, self-maintenance, is more effective, or can be, more cost effective, while also showing, outcome results that hospital systems can't ignore it. And so when they're going to adopt a digital strategy, they're either going to figure out that, hey, we want to integrate dozens of these things independently with our IS operations and figure out the nuances and complexities of that, or they're going to choose an aggregation platform, a centralized platform to do all of that. And I often liken ourselves to the Surescripts of digital health. You could choose to put all of Roche's drugs in independently, or all of Merck's drugs in independently, and figure out how to create a prescribing module against each and every one of those kind of components. But our continued belief is there's going to be more and more digital health engagement tools that a clinical operation wants to enroll patients in, and then it's not enough to just, I gave the patient something, and I don't care if they did it or not. You're going to have to care if they did it, and we're the entire remote patient monitoring kind of componentry to bridge that. And if we do that at scale, we're now working with over 20 of the largest IDNs in the country, and we do that at scale, and we sit at the RPM against all of that, the aggregation of all the connected app and device data. We want to be the benchmarking of digital health effectiveness. We want to know what app or program or service or cadence is going to work best for age, gender, ethnicity, geo. There's kind of so much of this digital health activity is behavioral change. And I don't think there's a one size fits all against behavioral change. You really have to get in the nuances of that patient's lives or affinity groups to really affect behavior. And I think you're going to see segmentation over time as to, this diabetes management, app really works well for these patient populations, but this one does a better job for this group of patients. And it might be in the telehealth or the coaching or the verbiage or the outreach cadence or whatnot. But that's how I see the evolution of the space on that front, and why I would hope that we're established as the necessity kind of central aggregation point for provider systems against the fragmentation of digital health.
I love that. Sorry, Josh, you had something?
No, I was gonna say the same thing. I was gonna say, I hope you're right, because for all of us in digital health, we know that if Xealth can grow and succeed, that's a benefit to patients and other digital health innovators out there. One of the things I think Alan was finding in research about you is, you've mentioned coming up against this common attitude in healthcare of, if it ain't broke, don't fix it. Yeah. Did you run into that with Xealth specifically? And if so, what did you do to kind of overcome that?
Oh yeah, I mean, absolutely. And you fight it every single day. If someone asks, who's your competitor? I'm like, competitor is stasis, somebody not doing anything. like, I don't know, this digital health thing, I don't know, we don't have any of that. We don't need that. Like, like patients come in to see me in my office. That's the way that healthcare is delivered. And so, overcoming the stasis is probably the single biggest challenge for all of us that are trying to modernize healthcare in the US, right? And so then, a lot of times, motivation is FOMO, right? Fear of missing out. And so like, it's either fear or greed. And so is a hospital system concerned about their finances, or concerned about the competitor down the road? Or are they concerned about the payer dynamics? They're concerned about their margins, being, compressed, are they trying to operationalize and strategize based upon like some fear dynamic of what's happening to them in the market? Or is it greed that, they serve in a, highly compensated, geographic monopoly, kind of positioning, or the payer dynamics are favorable to them, or whatnot, and they just want to continue to optimize, around that moat and keep that kind of, advantage in the market positioning that they have. So kind of understanding the market dynamics, that's one of the things about healthcare. Like, I worked in global kind of businesses before, Android and iOS are, globally, available, right? And here in healthcare, you talk about the US national healthcare system, but in reality, state by state and reimbursement structures and payer dynamics and local, geographic, kind of density structures and employer, density mixes, all of these really play a role. And so, there's more complexity in trying to understand the motivations of our customers who are hospital systems. But, in some cases, it starts with everybody talks about wanting to improve better patient care and cut costs and stuff like that. Are they making meaningful investments towards, trying to change their business model to achieve those talking points?
That's a great point. So Mike, actually, you had a really brilliant conversation with Bill Russell on the Insights podcast a little while ago. And I especially enjoyed, you had a comparison that you made between Uber and healthcare. And you were saying with, ride sharing apps like Uber, the event itself is a little variable. You don't know what kind of driver you're going to get. You don't know how they're driving, but the experience around ordering that vehicle is seamless. And it's a great experience, very positive overall. Whereas with healthcare, it's the opposite. The experience around the provider visit is a nightmare. And it's, all these moving parts, and it's not very well oiled, but the visit itself is usually very positive. So my question is, how have we got here, and what can we do to leverage technology to solve this issue?
That's a very multifaceted question, but first off, I like how you included seamless in that comment there. So nice to get your own company plug in there. I don't know if you did it on purpose, but I heard that. So congratulations. Look, Uber is not perfect, but it solved a lot of problems. Ride hailing in general. Like, instead of making a phone call to try and book a yellow cab or stand on a sidewalk and try and wave someone down, you'll just use an app and geolocate and seamlessly do that. Yet making an appointment to see a primary care doctor or a specialist, is full of logistical hurdles between trying to schedule it, whether you still have to make phone calls or you can somehow do it online, and then where do you park and how do you find it in the labyrinthian hospital system complexes, and sit in a waiting room for n number of minutes or hours. You get your little 10-minute window, or with the doctor, and then you have to leave and you're confused around what the doctor told you, and it's just the little brief window with the doctor, the empathy, the trust, the doctor's professional recommendation. I mean, I think doctors and nurses are, the highest regarded, trust professions in the country, maybe the world, but, they're held in high regard, and people cherish those few minutes they get face to face with that trusted clinician. But there's so much just, challenge and logistical inconveniences around getting that little 10 to 15 minute window with that patient. So how do you improve that? And and straight up telehealth is one way perhaps if travel is inconvenient. The form filling and paper-based form filling and things like that is another thing that you can optimize around that. The mobile and digital engagement touch points of like, wait, when was I supposed to stop eating? And, when was I supposed to stop drinking before this? And wait, what did they say about the PT exercises? Like, wait, why does this photocopied, piece of paper that's so illegible because it seems like it's been photocopied 20 times over? Why isn't it just a video or, showing me exactly how to do this? So, using technology to automate around the edges can still improve that clinician experience. One thing during COVID that we found, I could talk through the whole COVID dynamics and how it affected Xealth, but one thing in particular is we had lots and lots of, a pregnancy app. It was more what to expect when you're expecting. Here's information, an anxious mom, trying to educate her about, the pregnancy journey through the gestational stages. And during COVID, whoops, we're in a world of telehealth. How do we make just this app more actionable? So, pretty much every single one of our customers now started shipping blood pressure cuffs and scales that connected in that app. And therefore you could have a telehealth experience with that healthy mom. And if her vitals were showing, just reasonable, within bounds health metrics for that stage of the gestational, journey, then the clinician didn't need to see that patient face to face. And it was convenient, it was effective, and it led to, huge cost time savings, around the clock. And that's just one example where using technology, you can improve a consumer experience for an otherwise healthy checkup. And we did that across the board on surgical prep things and, post-surgical recovery. And, when you start thinking about hospitals and, we started, talking about some of the health inequities, like, post-surgical recovery, some patients, and they live hundreds of miles away and they were expected to come in and see the clinician for a face-to-face visit. Like, oh, you're fine. Okay, see you. It's like, you can do that, now using technology and components and devices that monitor some of the vitals associated with that patient recovery. So, I just think that you're not going to replace the doctor, and I don't think telehealth is going to replace face-to-face visits in its entirety, but it's a convenience offering in certain dynamics, and then the prep before an appointment and the discharge with new instructions against disease management or recovery or medication pickup or whatever can all be greatly enhanced via the technology. Versus, I jokingly say healthcare operates at the lowest common denominator. Just because 5% of Americans don't have access to a phone, or I don't know, 10% of it, like, okay, we're going to go down making phone calls and sending faxes just so everybody in the country has a chance to engage. So you're disenfranchising the 95% just to give an experience for the 100%. And so how do you reach patients on the convenience and their prep and their engagement structures that they want to engage against their kind of readiness to adopt a technology solution? It's not a one size fits all, which is where healthcare has devolved to. And if hospital systems don't do a better job of trying to meet these patient needs, you're seeing huge amounts of segmentation and private equity dollars and payer dynamics and startups and retailers trying to pull off profitable segments of patient populations, leaving hospital systems further in a financial hole because they're largely just becoming safety net hospital systems for Medicare and Medicaid patients.
Mike, you brought up a really good point just now in terms of healthcare often sinking to the lowest common denominator in terms of access. And, I know when we started Seamless, we would often get questions about, well, what percent of patients actually have internet access and therefore can use a digital solution. But then I always wondered, well, every health system, even the smallest, hospital has a website now, and you need the internet to access the website. And so if that were true, that we don't want anything that requires internet access, you wouldn't have a hospital website. So I always felt that kind of strange, actually, that they would bring that up as I get why they're saying that, but they still have websites. So any case, before we got to the fast forward lightning round, I did want to ask you one more question, Mike. And, you have probably so much data now on activity on Xealth and prescribing habits and things like that from clinicians for digital health applications. I was curious, any particular insight that you found surprising so far in terms of prescribing habits or sort of use cases that had been more common than you would have thought? Just wondering if anything was surprising to you so far.
Yeah. So I mean, we've actually delivered, I don't know, content or apps or services against probably 50 different service lines or sub-segmented service lines or whatever. So we're kind of agnostic as to what you want to engage the patient. 95% of the things we've prescribed, here's a data point. We just crossed this over in the last month. We've done over 10 million prescribed events on the duration of Xealth's history. So 10 million digital things prescribed to patients across our provider customers. That's a number that we're proud of. 95% automated. So nobody's clicking a button. It's lined up against a rule algorithm that, pre this appointment type, pre this surgery type, send this to the patient. Post discharge against this diagnosis, send that to the patient, or post discharge from a surgery, send this recovery pathway or this RPM platform to a patient or whatever. So the automation is important for just the pure volume numbers. You can't automate everything. We've integrated behavioral health solutions, I think, at like 7 or 8 different systems. None of it's automated. Hey Josh, I'm sorry you're depressed. Here's an app for it, and like, is that the messaging? Post a doctor visit? No, it's like, Josh, I'm really sorry. Like, you're having a hard time. We could put you on meds, but before we try that, let's try this digital therapeutic. It's really been showing strong results. I think you should, kind of have a go at it. And I can monitor your health remotely, and intervene as necessary, to get you in if needed. But let's start with that. And so when you do have that doctor face-to-face clinical conversation around things, I mean, we're showing 60 to 80% engagement rates in the things that the doctor tells the patient to do. If you automate it, you can drop, depending upon the service line, anywhere from like 10 to 30%. And if the clinician doesn't actually have a conversation with the patient around that. So there are certain instances where you want to automate where you can to reduce clinician burnout and repetitive tasks and things like that. But there are a lot of things where you need that clinician conversation to really bring it home, and then you need governance and protocol and kind of, you have to build it into the workflow of that clinician. If the patient meets this criteria, thou shalt click this button. And sometimes we automate enrollment in maternity care apps, but if the mom's under the age 18, that requires subjective decision. Let's have the clinician make a conscious decision and click the button in that instance. So that's kind of one thing. Another, my broadest insight, and this goes back a lot to the prevention, and it goes to the differentiation of economic business models. The poster children of digital health success, maybe in the macro world of, consumer payer, dynamics, Livongo is the high water mark, but a modus that's there, or Noom, or whatever kind of like consumer or payer or employer kind of focused solution, they don't really fly in the provider world. The hospital system isn't capitated. They want to manage that diabetic patient, but they don't get paid to remotely track or engage or monitor that diabetic patient. And so granted, we've integrated lots and lots of diabetes solutions. They're typically only to that hospital system's own employee base, or maybe to an ACO structure, or maybe against a grant or research-oriented, kind of initiative. But you're not seeing broad-based chronic care adoption occur across provider enrollment in digital tools. and that's CHF or hypertension or nutrition or diabetes management. The one that I think is kind of like jumped the shark a little bit, and we've seen the broadest adoption of it, is behavioral health. And that's because of the crucial challenge and the shortage of qualified therapists available, and so we've seen hospital systems use community benefit funds to pay for it, and other kind of like, and in some cases they're getting payer reimbursement to enroll patients in it. That's one thing we'd like to see more happen, is payer provider collaboration. The payer's already paying for that solution, and it fits that the clinician could recommend the patient into that solution. It's a win-win for everybody, it seems like, but we've not seen that done at the scale that we would like to across our provider customers and the nation.
Interesting. All right, well, Mike, we're coming up to the hour, so let's shift over to what we call the Fast Five lightning round. 5 questions to get to know you a little bit better for our audience. The first question we have is, what is your favorite book or book you've gifted the most?
There's a book called Freedom's Forge. I actually don't know the author. I apologize on that. When I read so many books on Kindles, I sort of forget some of the details around it. But Freedom's Forge was around America building up its armament capabilities, the logistics, the supply around World War II production to go to war. And this is the industrial might of the U.S. And so the auto manufacturers started building tanks, and the ball bearing manufacturers started making machine guns, and it just talked about the dynamic nature of American capitalism, and it created the cost plus structures that exist in defense contracting and things like that. But it was a crazy good read around logistics and supply chain and dynamic creation in just a very, very short period of time. And we've seen the supply chain dynamics in this country and how long it takes capital projects to exist now. You're like, somewhere we're stuck in like this this nature of too much process and inhibit some of the dynamic capabilities. I read a lot of history books, and that kind of like hit me at some of the themes I like to engage in.
Mm-hmm. No, that's great. I think it's especially relevant for healthcare as well, as we're at kind of this precipice with digital taking over, and can it adapt to make change in that way?
Yeah, I've read a lot of healthcare books, but some of them are too depressing to bother.
They're all just saying the same thing for the last 20 years now.
Fair enough. Second question that we have: how has an apparent failure set you up for greater success?
Oof. Well, I could talk on the micro level or the macro level. You referenced some of the great companies I've started in the past. I also co-founded, I was not CEO, but I co-founded a company that raised $400 million and went bankrupt. And it was in the telecom space, and they take big swings in that industry, and it was tough. We had hundreds of employees, and we had to lay everybody off, and we had we owed tens of millions of dollars to vendors and partners, and when we went through the bankruptcy proceeding, they got left holding the bag, not being compensated on that. And then we had tons of investors who put money in the vision and story and the product that we had built. These were sophisticated investors, Intel and Qualcomm and MTV and private equity funds and venture capital groups, and so eyes wide open that they invested in the vision. Mm-hmm. But immediately from that was my first CEO role, and that was Swype, and it was a much more concentrated product delivery, and it set my chops for being a CEO and knowing how I wanted to run a company versus where I was maybe the co-founder but not the CEO. But you also wear a much greater level of responsibility. You acutely feel some of the trust that people are placing on you whether you're hiring someone or someone's, writing an investment check in you, or a customer saying, okay, I'm trusting that you're going to deliver X. And so, I own that responsibility across the organization and sort of feel that. But you got to get knocked around a few times to learn some lessons in life that create some perseverance of things that you want to do differently.
That's great. And I have to admit, Mike, I was one of your customers at that company. It came to Canada for a little while, and I jumped on board with TELUS that I had at the time. They had the aint and everything. But I admire the ability to really pick yourself up right after that, because you went and formed your next company very shortly after that. So that was really admirable. Question 3 that we have: would you rather have super strength, super speed, or the ability to read people's minds?
Super strength, super speed, or probably the ability to read people's minds. I don't want to, I don't want to use it like deceitfully in any manner. But the speed and strength are just individual capabilities, and I think there's people and community and humanity that I want to play a part in, and so those other two didn't touch on any of those kind of like social humanity components. So not that I need to read your thoughts or deceitfully negotiate against you and knowing what your answer is or whatnot. But I just think the empathy against other people and ability to communicate plays into like how I want to live life.
I love that. Question 4: what is something in healthcare you believe that others might find insane?
That's a good one. I'm going to be a little controversial here. Sometimes providers don't have the patient's best interest in mind. When I first got into healthcare, you've got the internet destroys middlemen, right? Like you book a flight by yourself. You don't need a travel agent in the middle. And so you had a doctor and you had a patient. What are these insurance companies? They're just annoying middlemen. They just skim. However, back to the prevention kind of conversation earlier, I think payers will pay for preventative services that are more aligned with a long-term health outcome for that patient, whereas the provider won't. And so the payers, their economic incentives are better aligned with patient outcomes than hospital systems. And so you might find yourself where the doctor-patient relationship, as sacrosanct as it is, might not be, having the patient's best intentions in mind.
Yeah, that's a juicy insight. Question 5, this one is a pandemic lockdown related question. What is one hobby or activity you've gotten into since the beginning of the pandemic?
Running again. I've done a lot of marathons. Last one was in my 40s, a couple of years, 5 years ago. I'm going to do the San Diego Marathon in 2 weeks. Wow. So, I've just gone on longer runs. It's my sanity. I listen to podcasts or music, and it's my, I'm like you guys, I'm working more from home. I don't have the same social dynamics. My commute used to be my exercise. I'd run to work or bike to work every day. And that's gone from a commuting schedule. So running has been my sanity break to pick back up on a hobby that I've previously engaged in.
Awesome. That's great. Well, Mike, thank you so much for coming on the show today. You've shared a lot of insights with us. Your career has just been fascinating. I really hope that our audience takes away all the pearls of wisdom that you've embedded throughout the conversation. So I just want to say thank you again. And to our listeners out there, you can find Mike on Twitter at McSherry, I believe it is, McScary. And that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and you want to learn more, visit www.seamless.md. Thanks, Mike, so much.
No, thank you, Alan. Thank you, Josh. And I hope that we find a way for our two companies to work together at a existing hospital system or some net new customer that we could work together with. So thank you very much for your time and the great questions.
Thanks, Mike.